Hi, everyone. Good afternoon. I'm so pleased to welcome you here today for our conversation. I'm Ali Fodi. I'm a program officer here with our primary care priority area at the New York Health Foundation, and we have a great conversation today with two medical assistants across the state to describe their stories and what it's like to work on the ground providing primary care. So with us today, we have Phylisha Worthington from Universal Primary Care in Western New York and Stephanie Rodriguez in the Open Door Family Medical Center in the Hudson Valley. I'm going to set the stage for us before we dig into the heart of our conversation. But before I do, just a few administrative items. Like you see in the chat, we have closed captioning available, so you can find an icon at the bottom of your screen and a banner at the top to find your way to that functionality. We'll be recording today's session and we'll send out a recap after the fact. We want this webinar to be as participatory as possible. So I'd encourage you to drop your name and your organization in the chat, say hello, and also please include your questions and your comments. I will lift that up as best I can into our conversation. All right, so what brings us here today? A conversation with medical assistants. First, who are medical assistants? Who are MAs? What do MAs do? MAs are a core part of the primary care team, and we've all interacted with MAs in our own medical appointments. MAs do any number of clinical and administrative duties under the supervision of a clinician, things from taking vitals, taking patient histories, drawing blood, preparing us for exams, scheduling, scribing, you name it. And it all happens differently in each care setting, depending on the region, depending on the type of practice, depending on the size of the practice, community health centers, hospitals. MAs all work differently, but increasingly, folks are focusing attention on medical assistants because of the roles that they can play on the primary care team. One of those reasons is that we see the medical assistant workforce growing pretty rapidly. So there are about 40,000 MAs here in New York State, and the profession is growing more quickly than a lot of other healthcare professions. So about 30% in the next decade is projected. And this is at a time when we see that there's a struggle to recruit and retain clinicians, that there are shortages and strain across the healthcare team. And so increasingly there's attention on what does it mean to bolster MA's role on that team so that the team works better together. MAs can do all that they are trained and able to do, and everyone can practice at the top of their license. We also just know that patients get better care when teams work better together. And we've particularly seen that in the context of medical assistants. When MAs play bigger roles on care team, when they're empowered to, patients better manage their chronic disease. Providers report better satisfaction, better morale, the teams are more efficient. And we've seen that happen in our own backyard. So here in New York City, for instance, Community Care of Brooklyn, primary care practices associated with Maimonides Medical Center, they've trained their MAs as health coaches and saw that patients improved their blood pressure and cholesterol. Or here at Northwell Health, MAs were enabled to call patients after they had normal lab results, and clinicians reported that the team worked better together, that there was reduced burnout and improved functioning across the team, improved morale. So we know with all this that there's a movement towards elevating the role of MAs to respond to some workforce crises and also to capitalize on what MAs can do well to support patient care. That enough would be good enough reason for us to have this conversation today, to shine a light on the MA profession. But there's also one other reason why it's particularly timely that we're having this conversation, which is there are currently policies under consideration here in New York that can unlock the potential of MAs in the ways that we've been discussing. And in particular, the governor in her executive budget has proposed that for the first time, medical assistants be allowed to vaccinate patients. And to be more precise, that clinicians, physicians and physician assistants, be allowed to delegate that task from themselves having to vaccinate or nurses or other clinicians having to vaccinate to medical assistants, catching New York up actually to the rest of the country. As best we understand, every other state allows those clinicians to delegate this type of task to medical assistants. And we can all understand why this is a problem. We've seen it through COVID, in knowing that in a need of a public health crisis or just in general to get our communities healthy and provide that type of preventive care like immunizations, that we need all hands on deck and we need everyone to be able to practice at the top of their license. So now is an exciting moment and a pivotal moment to discuss this. NYHealth doesn't conduct lobbying. We are prohibited from supporting lobbying, so we're not going to call for action on that particular policy. I just bring that up to show you what the backdrop to this conversation is, to emphasize why something like that is important, and if such a policy were to come to pass, why that would matter for folks on the ground like the MAs we have in our conversation today. So you've heard enough out of me. I will now turn it over to answer some or ask some questions of Phylisha and Stephanie. They're going to describe for us their day-to-day work, the opportunities they see, the meaningful patient care that they offer, the challenges that they and their care teams face. And that'll be great to get their experiences and their perspective. It won't be a direct commentary on what it's like to work at UPC or what it's like to work at Open Door. Instead, we just get to tap into their knowledge and hear their real stories. So with that, let me start with my first question, which is, what was your path to becoming an MA? So who are you? Where do you work? How did you become an MA and what's kept you in the role? So I'll start with Phylisha and then Stephanie.
So my path to becoming an MA started in my mid-20s. Both of my grandmother and my mother were LPNs, and I had decided I wanted to be in the medical field like they were. When we were discussing that, they had said that they had suspected that MAs would be taking over LPN positions in the office setting within 10 years. So I opted to go to the medical trade school for a medical assistant. And when I first started at Universal Primary Care, I was actually the first MA hired here at UPC. And at the time, we had 3 LPNs to 1 MA. And when I say pods, that is 3 to 4 providers. So we're pretty much a one-to-one ratio with our providers. But there were 3 LPNs versus 1 MA. Now, present time, it is completely flopped. And now we have 3 MAs to 1 LPN or RN.
Thanks so much, Phylisha. And you really just underscored that growth of the MA profession in practice and what's attracted you to the role in that type of career of service. So Stephanie, what about you?
So I started the MA. I decided to go for a medical assistant back in 2013. And I started school in January 2014. I went to the College of Westchester to become an MA. Then I graduated in 2015, but I didn't start working as a medical assistant until January 2017. Or I started looking for jobs at the end of 2016, and then I got a call from Open Door, and they offered me the job. I was very grateful since I didn't have any experience, and it took me like it was a big gap from when I graduated to when I started looking for jobs. So, and since then I've been growing as an MA, and now I'm a supervisor of medical assistants.
Thanks so much. And so I wanted to ask what, Stephanie, you teed me up perfectly. I want to ask what your day-to-days look like. And so in your case, that's both what your day-to-day looks like as an MA yourself, but also as a supervisor. So if you want to talk us through what that means for you in practice.
Well, as an MA, our day-to-day work is, we come in, we prep our charts, we huddle with the providers in the morning so we can discuss about the morning schedule. We go through every patient. We check what the patient might need, any labs, if the patient needs any future appointments. We get all that information when when the patient does come in, we already know what to do for that patient. And we can do everything. So when the provider does go in, it's a little bit more easier for them because they already have all the information, and the patient doesn't have to wait a long time in the facility, right? So our job or our goal is to try to get the patient in and out, and still get everything done for the patient. as a supervisor, my job is to make sure that the other MAs does exactly that and that the patient leaves here, satisfied with the care.
That's great. And I have to tell you, this is exactly why we wanted to have this conversation, because there are things that we know about based on practices of other health systems or research. And one of the things that I've been able to learn is something that you just talked about that happens in practice, which is that when MAs are involved in huddling in the mornings, in patient prep, at least what the research says, is that this means that there's better patient satisfaction because it's a quicker, more efficient encounter. Teams are working better together. They feel like things are more efficient and everyone feels more satisfied and less burnt out in their role. So to hear you say that that's what's happening in practice, it only emphasizes that federally qualified health centers like Open Door and across the state and across the country are finding those ways for the teams that involve MAs to work well in that way. So Phylisha, what
Yeah.
about you? What does your day-to-day look like, or what does a day look like for you?
So I also do chart prepping, and pre-visit planning is what we call it, for preventative care. So, we look ahead before the patient comes in to see when their last mammo was, when they're due. And we do that for mammograms, pap smears, colorectal screenings, heart disease. We also screen for depression and anxiety. All of that. We also do BMI screening as well. So we know that when the patient, before even the patient arrives, we know exactly what we're going to be doing with that patient and what they need for their preventative care. Then I get the patient from the waiting room. They come in, I do their vitals, I review their medications with them, and then their medical history as well. And I also help in simple procedures as IUD removal, replacements, Nexplanon colposcopies, endometrial biopsies, Nexplanons, EKGs, and I do all of the ordering of the labs as well. I work with women's health a lot. That's my main role right now. And so with women's health, a lot of it is very like ACOG by the book. So certain trimesters, we know what labs we have to already order. So I usually have those already pre-ordered and ready to go for the patient along with their next appointment ready as well. So it's a very organized visits for our women's health team and our patients.
It's so helpful to hear. And I'm smiling to myself because I was trying to think about my own stories, what makes me passionate about medical assistants, just because the whole purpose of this conversation is stories hearing from you all and what medical assistants have meant in my own patient care. And I was smiling because my positive and really meaningful experience was in women's health as well, to think about an MA being the person on the care team, April in my case, who was able to have the longest conversation with me, talk about my medical history, answer my questions, help me navigate planning for some procedures, medications, and how to contact the pharmacy. It was clear that scheduling everything ran through April in this case in my clinic. And so to hear that in your work in women's health as well, that type of planning for procedures and knowing what preventive visits are coming and what's needed, and then executing on that really rings true for me. And I imagine a lot of folks here we have on this call. You two have already answered this to a degree, but I figured I'd dig deeper on this, which is, what is it like for you to work with the rest of the care team? The physicians, NPs, PAs, the LPNs you mentioned, the pods. How do you work and how do you share tasks between your care teams in the pods or in general? And maybe Phylisha, we'll get started with you and then turn to Stephanie.
Okay. Like I said, in our clinic at this time, we are lucky enough to be one-on-one. So we each have our own provider, even like an LPN will have their own provider. What makes it a little different is what you had brought up in the beginning was there are certain things we cannot do as medical assistants, like give vaccines. So we actually utilize Teams and we'll like message floor nurses to give our vaccines for the provider we're working for that day. So that's, luckily, we started just using Teams this past year. Before we utilized Teams, we were just like kind of walking around the building trying to trying to find an LPN or RN to administer the vaccines. And I also work very closely with the OB-RN, and I get a lot of calls for the OB, but if anything needs to be triaged, I take a message and send right to her, or I will call her up myself if it's something very urgent and say, you need to triage this patient right now. So our OB-RN does all the triaging.
Really helpful. And Stephanie, sorry, before you chime in, I did just want to ask a follow-up question, Phylisha, because what you brought up in the vaccination example was so interesting in the sense that now it sounds like thankfully you have a tech platform where you can pull nurses in, but you still are having to step out, it sounds like, beyond the care team of you and the provider in caring for a patient. And then you have to pull another nurse in to be able to vaccinate. So you have to work outside of your pod, as it were, to be able to get that patient the immunization that they might need. So can you just describe what that workflow is like? Is it
It interrupts the workflow. That's one of the main things that I wanted to actually emphasize for today, is that if we were able to do vaccines, I think our workflow in patient care would be a lot better. It would be more efficient, because we do have to kind of break up the appointment and go find somebody. If a nurse isn't available right away, then they're holding up the room, so we can't get them, I don't want to say in and out, but they're waiting in the room for a vaccine. And it could be up to, 10 to 20 minutes waiting for a vaccine when, our team or I could have just vaccinated them myself.
and it's not in and out. If patients want to have an accessible and easy experience, and so it's not trying to churn patients out, it's having the best patient care experience possible and for you to make the most of your time and the team's time. So that makes sense to me. All right, Stephanie, how do you work with the rest of the care team?
So basically we do almost the same thing as Phylisha. Uh, the only thing that when we do the huddle, the nurse is always there. Our mental health specialist, she's also there. And our patient advocate, she's also there in the huddle, meaning that anything that the patient need, not only uh, like medical wise, but if the patient have already had a positive depression screening, we already have our mental health specialist there. So she already knows that at some point during the day when the patient is here, she will need to see that patient. And if that patient is not on her schedule, we could add it before the patient gets here. And we add it around the time that the patient will see the provider. The nurse as well, he will know which vaccines the patient will need. So he already ready for the patient. So we do basically the same with the previous planning. We check if the patient is due for everything. So the whole team is there. We also use Teams to communicate with other team members. So yeah, that's how we work together as a team.
I appreciate that. And it sounds like in your experience that MAs play a really pivotal role in being able to provide linkages to care, especially for mental health needs. And so we know in this time of real strain and distress how important that is. So it's really interesting to hear what that looks like for you in practice in the primary care and mental health space relative into the women's health space. Let me say for one moment, I see these wonderful questions coming in the chat. So thank you all. I'm writing those down and we're going to incorporate those in the conversation. And we also see a lot of great folks here from different primary care providers all across the state, health educators, nonprofit professionals. So please do keep chiming in with your thoughts and with your questions. I wanted to ask you both around an example, a time that you have that sticks with you about your having a meaningful interaction with a patient and how you supported them with their care to get and stay healthy. And so we're just going to keep switching back and forth. But Stephanie, why don't you get started?
Um, I I felt like that was a hard question for me that I couldn't answer because me personally, I try every time I'm with a patient, I try to give them the best care, I can in my position as an MA. But I know that before, when I used to work in the women's health department with the midwives, I remember some occasions that the patient will come in and uh, probably their pregnancy didn't turn out, as good as they wish. So there were some steps that we needed to make in order to help the patient um, with the transition of losing the baby. So I will be with them and with the midwife. We will call um, the be his person, we will call them so they will be able to speak to the patient. And, in other situations, we would just send a message to the be his to be his, but in these cases, we need a be his to speak to the patient like right there before the patient leaves the facility. So I guess that's the best that like touched me the most, because I'm a mother and thankfully I never went through that, but you feel it when you're speaking to the patients and they're going through these sad situations.
Of course, and the ability to have a really empathic encounter where patients feel seen and feel like they can express not only their health needs but their stories. And so to know that that's been experience that you've had not just in this job but in previous jobs
Right.
is exactly why we have a conversation like this. Phylisha, what about you? Did any stories come to mind?
So for this question, I do feel it was difficult to answer because I feel like I try to play an important role in every patient care and encounter that I'm in. But specifically, I am also, aside from being a medical assistant, I am also a lactation consultant. And I feel every time I encounter a mom and baby that are having difficulties with lactation needs, being able to help them understand and educate them on feeding a baby. And it's not just, breast is best or, formula is bad, which I've been like, oh, I want to breastfeed. They're a lot of times so stuck on wanting to breastfeed. They forget that ultimately a fed baby is what we're looking for and is a healthy baby. And that myself, no one knows if I was breastfed or if any of you were breastfed, and here we all are healthy adults. So anytime I have a lactation consult is when I feel like I'm doing a really important role in my job.
Absolutely. And I think that example also points out what it's like to match the care to patients' needs and patient goals and the importance of an individual encounter. So to support birthing people through how they best need to care for their families and their babies and your help to navigate that and to counsel them in ways that they feel supported. So, oh, I do thank you so much to folks in the chat. I do see, thanks so much for bringing up this policy note. Again, we wanted to make people aware about this current policy proposal. We're not advocating for it, but just as a piece of clarification, it does look like not just physicians and physician assistants, but also nurse practitioners will be some of the professionals that are able to delegate these responsibilities and then supervise and train MAs to be able to provide vaccination. So if you're interested in learning more, you can see the link. Again, we're not suggesting you do anything with it, but just for your own education, this is a policy that there's some real movement behind and some proposals there. All right, this is going to relate to a question in the chat. One of the questions that I had for you is around what changes would make your work easier. I think, well, actually, we'll get there. Let me pose the question in the chat first, because it makes sense to say, someone in the chat asked, what are the pain points in your job? What's something that makes your job particularly difficult? And there could be any number of things there around staffing, around patient care, or otherwise. And I would say your experiences are all fair game. We know it's not a commentary on your particular work or the folks that you work with or your clinic, but rather what are some things that you've struggled with that you want everyone on this call to know so we can take that knowledge into our own work? Stephanie, why don't you go ahead?
Well, it all depends because if we could have a bad day either um, with the staff or we could have a bad day with a patient. We're not always going to have happy patients. Patients sometimes are coming with any type of problems, and then they take it on us, right? So we try to do our best to stay calm, but just today we had a patient. He was super rude to our front desk staff, but then he was nice to the MA, because the MA already know the patient, so she already knows how to work around with the patient. So I guess having to deal with just in my position as a supervisor, yes, I want to support my staff from this situation, but also I like to try to understand the patient, like where is the patient coming from, what is going on, why. And sometimes by just talking to them, you can calm the patient down. You can make them or help them, you know, go home like in a like at ease, and not leave with a bad impression that, oh, like open door staff, like they don't listen to you, they don't care about you. So I just try to both support my staff and at the same time try to help the patient.
Right, Phylisha, what about you?
I would say difficult patients, and I would view difficult patients as the non-compliant patient. So, someone that is sick, but they're not compliant with their preventative care needs or with what they need to do throughout their pregnancy to stay healthy for themselves and the baby. I would say that's probably one of the most difficult things as an MA, and probably in any sort of medical work field, is just being with patients that are non-compliant and you just want to help them. We are lucky enough, like I said earlier, that we are a one-to-one. So for us, staffing is not an issue at this time. Years ago, though, before we were one-to-one here at UPC, staffing was an issue, and it was running 4 providers, and you've got different pre-visit planning that you're doing, and that was pretty difficult. So in the past, workload with dealing with different providers was very hard. Moving to a one-to-one basis has really helped improve that. But many places I know are not as lucky to be able to do that because of staffing issues.
I appreciate you bringing that up because one, it helped answer one of the most recent questions in the chat around the one-to-one ratio, but then also you bring up an experience that we know is happening across the state around staffing challenges, staffing with MAs and other care team members, and how that can put a strain on patient care. So that teed me up really well for so thank you, chat folks. It teed me up well for one of the questions that I had for you around what are some things that could make your day-to-day work better? It could be big, small. What's something that could help solve some of those pain points that folks in the chat brought up? And there's no perfect answer. It could be anything that comes to mind, but if there was something that could change in terms of policies, in terms of way that the team works together, what would make your days a little easier? Oh, Phylisha.
Okay. So for this question, I had put in large letters to be able to vaccinate, to be able to not have to break up my day to go find an LPN or RN to do that. That does do a lot of holding up for our care team and rooming patients. So that's really all that I would say. I know that like the provider I work with, we share an office. So we're talking in between each patient. We do like everyone does a huddle in the morning, but then after each patient, we're also doing like little mini huddles as well.
For me, I think that if we have more staff that can help the MAs, because MAs do so much during the day. There is so much that has to be done. Yes, we have to do vitals for the patients. We have to screen the patients. But also we have to call the patients for the next day. And sometimes there is no time to do it. So sometimes they either have to leave late. Sometimes they have to leave to go to lunch late because they want to get everything done before the end of the day. So if we would have someone just for that to call the patients and ask the patients all of the questions, like the screening questions. So the next day when the patients do come in, the easier code could go smoothly. And the MAs will only have to worry about the vitals and not asking the patients all the questions. And also I'll say with the vaccines, yes, it will be very helpful if the MAs could do that, like vaccinate the patients, because at least in my site, we only have one nurse. And if that nurse is out on vacation or out sick, that leaves us without a nurse. So now we have to call all those patients in his schedule so they can come in another day, or any patient like children, for example, if they need vaccines, those patients have to come back just to get the vaccines. So I guess it would be very helpful if that could be done.
Wow, it's a really it's a sobering story to hear, to think about getting ready for back to school or anyone needing a flu shot, an older adult, and having to think about a whole nother trip to the doctor to be able to the center to
Mhm.
be able to get those immunizations done. And I want to build off of a few things that you just said. The first of which is so important, Stephanie, which is we get really excited about MAs being able to take on expanded responsibilities because there's so much that can be done in
Mhm.
forming those trusted relationships in women's health, in supporting care management, in vaccination. But just adding more and more responsibilities on MAs isn't the solution, because MAs need supportive staff, supportive financial
Mhm.
support, supportive policies. Like folks in the chat are saying, supportive ways that teams worked well together in their workflows. And so there's real benefit in having the freedom and flexibility for MAs to take on more roles, but that needs to every practice needs to understand how that actually works for everyone on the care team.
Right.
I also wanted to pick up on what you just mentioned around vaccinations, because we here at the New York Health Foundation are supporting some wonderful researchers at the Fitzhugh Mullen Institute for Health Workforce Equity, and they have started to talk with primary care practice administrators and MA supervisors across the state to ask questions around, among many other things, this idea of vaccination and if MAs were allowed to vaccinate. And overwhelmingly, what they've started to find in their research is that 2 out of 3 practice administrators are saying that if this were possible, if this policy were to allow MAs to vaccinate, we would want our practices to be able to delegate that responsibilities to MAs. Or in community health centers, 8 out of 10 practice administrators are saying that. So each practice can make the decision for themselves, but what we're starting to hear is that many practices would opt in to that if it were possible. And many practices think that it would be feasible to do so because they would train their MAs in-house to be able to administer these vaccinations, because it's so similar to the blood draws that you already do and many
Mhm.
other procedures that you all are working on. So, all right. Thank you all for these great questions in the chat. I'm going to try and lump them together as best I can to continue our conversation. One question in the chat was around, so I think you both mentioned screening for depression and anxiety. And we also know that primary care practices are doing other screenings too, like screenings for health-related social needs, screening for food insecurity, housing insecurity, domestic violence, and other things. Are your practices, to your knowledge, doing those types of screenings? And if so, what roles do MAs play in that?
Uh,
Phylisha, yeah, please. Great.
Yes, we do social determinants of health, and they actually receive the packet at the front desk. They bring it back to us, and then we submit it. And then if there is a need, then we have care coordinators that work here at UPC. So then we let the care coordinators know that they were positive for social needs.
Stephanie, in your
So
practice?
same here. We do screening for depression screening, tobacco, alcohol. And for any of those, if it's positive for the depression, we have to let our biggest person know so she could see the patient right there. And for alcohol or tobacco, the provider will take care of it. We as the MAs, we just have to let them know this patient is positive for this, for that, and then they will take care of the rest.
Yeah, thank you. All right, I wanted to pick up on, we've had a good number of questions in the chat around training. And so I wanted to ask you all how you, Stephanie, you mentioned this a bit, but, or you both did, but how you both were trained. What training pathway did you take to become MAs? And then if you have any insight into how your colleagues, your fellow MAs in your practices were as well. But just talk about your own experiences there with training. Stephanie, go ahead.
Well, as I said before, I went to the College of Westchester. Um, I did an associate's degree, but I know that many people they do just like a certification for like 6 months. That could be done as well. Um, in school, believe it or not, I learned how to do vaccines. They taught me that, but then I've never done it because it's not possible, right? They taught me phlebotomy, and then when I started working here, they just trained me to do like any blood work, any mostly the screening and the vitals. That's what I learned the most here.
It's so interesting that you say that because, again, the research that I mentioned, there were conversations with medical assistants and focus groups, and folks had mentioned that if they went through training programs like associate degrees or certification programs, that learning how to administer medication injections or vaccinations is part of the training. And
Mm-hmm.
one of the quotes stuck out at me from these focus groups where folks said that we can draw blood, we can't administer vaccinations, but folks that work in Pennsylvania, 15 minutes away, they can, and we've all had the same training. So to point out that disconnect between New York and the rest of the country, including some of our neighboring states, and how that diverges from the training and
Right.
when folks are going through certification or otherwise was just an interesting thing to sit with. Phylisha, what about you?
So I went to a trade school. It was 14 months long. And then once I was hired on, we didn't have to do any, oh my goodness, what I want to say. We didn't have to like LPNs when they're in their school, they have to go to the hospital and do training. We didn't have that type of training, but we did the on-the-job training. So I learned a lot of hands-on when I started working. And most of the girls that I work with, girls and males that I work with, all went to the same trade school that I did. It's a local BOCES program. But we are 15 minutes from the border of PA, and UPC actually has a Bradford office, which is in PA, and their MAs do give vaccines. So it is funny, we all have had like the same training and they're allowed to do it, but we are not.
Yeah, it's a real world example of just what
Mhm.
we heard in those quotes. And I want to point out, so folks in the chat have brought up this topic of training of and recognizing, Phylisha, what you both said around there are any number of training pathways to becoming an MA, a BOCES, those trade school programs, the associate's degree, other degrees in community colleges, standalone certification classes, apprenticeship models, like for instance, Open Doors participating in an apprenticeship model for medical assistants. And so we on this call are not going to talk about all those different training pathways because that's a conversation for workforce researchers and folks that have thought about the MA pipeline. But to know that you both have different training experiences and that your colleagues have had different training experiences is exactly what we wanted to point out today. And I will just say that folks that have attended this call and expressed interest in around MA training and some of those policy issues brought up relatedly, we want to stay in contact with you as we continue to have conversations around medical assistants and their policy and practice needs there. All right, let's see what's next in terms of the questions that we've been getting from the chat. One of them is around, so this was a really important one. So folks, well, they're all been important, but you've been spending a lot of time describing how you support your providers, how, and in the care teams, in the huddles, in the visit prep, and how are you finding that providers and your other care team members are supporting you in the patient care that you do each day? So whoever has a thought first, just check in.
I could go.
Yeah.
Um, so ultimately, my provider, she's the brain of the whole thing. You know, she tells me what I need to do, what I need to order. You know, I also do her referrals as well. And like I said, we communicate. But if it wasn't obviously for her, I wouldn't be able to do any of the stuff that I do because I have to be able to have a verbal order from her to order the labs and helping her with the procedure. She'll tell me exactly what she wants for the procedure. If we're missing anything, she'll say, can you go grab this? But yeah, so we just, because it's one-to-one, I feel like I'm so lucky. We work very well together because we've learned each other's style of patient care.
Makes a lot of sense.
Yeah, it's nice when you work one-on-one and you already know your provider and your provider already knows you. Um, Providers do guide the MAs, every day with mostly anything so they can work together. And when you do know your provider, sometimes you don't even have to wait for the provider to tell you, oh, I'm gonna need this. You already know that the provider's gonna need it, so you already do it ahead of time. Um, so I feel like yes, providers do support the MAs the best way they can.
Of course. And I'll say it sounded like one of you had a knock on the door, and I know that you've got any number of things going on in clinic. So step away. The answer the door isn't a
Sorry.
problem. No, you don't need to apologize. That's you're right there in clinic. So you feel free to answer that. Let's see here. So Phylisha, you had mentioned so you became an MA, you've been working at UPC for a while now. I wanted to ask you, what's kept you in the job? What has kept you working each day in doing the tough but really meaningful work of patient care in a primary care setting as an MA?
I love patient care. The hands-on that MAs get to do is definitely what's keeping me here. UPC specifically is a really great organization to work for. I love working for an FQHC because we serve the, the underserved is what we do. And that just feels really good to be able to do that. So that's what keeps me here is I love patient care and I love my community too. You know, if you love the community you work in, it's easy to come to work every day and want to help the people that live here.
Again, I'll say what I've been able to learn from medical assistants like you all in these focus groups is that real calling for patient care and for serving the communities that you live in really rings true for a lot of medical assistants that keeps them in the work and keeps them motivated to contribute to patient care sometimes under really difficult circumstances, and challenging staffing models in not having oftentimes pay to really have a livable wage. I'm not saying in your clinics, but in general, what we know around healthcare, there's just that mission and that drive and that purpose is really making MAs an engine in patient care based on what motivates you all to support the care team to work well and to really make connections with your patients.
Can I just add one more
Oh,
thing?
please.
So I just wanted to add on top of it is in our area, we have sometimes a hard time keeping providers because we're so rural and it's hard to, there's nothing really to capture a family to want to stay here, right? Unless they want to farm. But so we have locums in and out as well. And I think it does make the patients feel more comfortable, at least knowing the nursing staff that is going to be here. And, we advocate for our patients as well.
Thank you for bringing that up because it's so important to think about the long-standing trusting relationships that care teams have with patients, and that is MAs and nurses, in addition to the clinicians, especially when there are challenges in retaining clinicians in an area like a rural area. So to know that you've been there for your patients for many years, maybe seeing them through women's health from along the continuum is just so important and speaks to the trusting relationships that MAs can build. Stephanie, I had asked Phylisha what keeps her in the role as an MA. You know, you've both been doing this work for a little while now, so what has kept you there?
Well, I love helping people. And especially in this community, we have a lot of Spanish speaking people. Um, so being able to help them, because sometimes when people come from a different country, they scared to see maybe a doctor here because of the barrier in the language, right? So when they do come in and we able to help them understand the provider and so the patient can live with a better understanding about their health. For me, it's very fulfilling, and being able to help them, it's all that matters to me.
It really, it's inspiring to hear what fuels you both. And Stephanie, in your example around be serving your neighbors that sometimes speak other languages and what it means to have a bilingual MA be able to connect with patients is really important. And again, it just for me underscores something that we know from the research, but we don't always get to hear on the ground, which is one, that there are models of MAs that are bilingual becoming health coaches for patients and really supporting them in chronic disease management and what that can mean for diabetes management or cholesterol lowering or blood pressure lowering. And then more broadly, here in New York, I said we have nearly 40,000 MAs. Over half of those 40,000 MAs are folks of color. And what that means for serving New Yorkers of color and forming trusting relationships, if MAs have lived experiences and come from communities and the patients that they serve, you both obviously come from your own communities and have a connection there. But what that really means for MAs on the front line to form bonds with patients and allow them to feel comfortable and support their care as a part of that team. I wanted to ask you the flip side of the coin, which is it's so clear what keeps you all in these roles and your drive around patient care and helping others. What are things that you found challenging? What are things that, if they were fixed, would help you stay in the role even longer?
Wait, I think I wrote that down. Um, I don't know. That's a very good question. So I would just say, if they move me, let's say, to a site that there's not as many, like the community is not, let's say, Spanish. Yes, I will feel good because I'm helping patients, but I feel like helping that community specifically is what brought me here and is what been keeping me here. So I guess if I go somewhere else and it's not that community, or not 100, or at least a little bit, like if we get some patients like from Spanish patients, that's what drives me, because I know, I was born and raised in a Spanish country, and that's what I've been seeing here a lot. Some people, they do not come to the doctor because they scare, because they feel like they're not gonna understand. So me being that middle point between the patient and the provider is what been keeping me here. So I don't know.
Appreciate that. Pooja, do you have any thoughts on that? I know it's a tricky question, and it's a big question too, but if there
Repeat the
are,
question.
sure. We talked about what keeps you in the job, and then we also know that in any job, and I'm sure in yours, there are things that sometimes pose struggle in our work. And so if there were things that you could see fixed, what would help keep you in the job? What would retain really talented and driven MAs like you in your work?
Um, I think right at this time, there's no bridge program for MA to LPN or MA to RN. I think some sort of a bridging program especially, MAs that really enjoy the medical field, because we are underpaid mostly. But if we were able to bridge into an LPN or RN, then that pay would of course increase. So I think I would focus on either a bridging program or just a pay increase in general.
I appreciate that.
Mhm.
On the financial side, of course, and then for people to be supported in their work and for their families, and also to think about, we all think about in healthcare career pipelines and career progression and what it's like to support a pipeline of, let's say, nurses or LPNs or MAs, and to think about unlocking the potential to be able to do that with training programs is just important to hear that that's an idea that's been on your mind. And it was one of the last questions that I had for you all, which is, have you considered training for another role, like a nursing role? And the answer may be it's not possible for any number of reasons, but has that thought entered your mind? And if so, what has made it possible or not?
For me, yes, I've thought about it. I've had providers tell me that you should go back to school. You need to go be an RN. But it is difficult when you're working full time and caring for a family, and there's no bridge. So all of the knowledge I have can't really be utilized towards an LPN or RN. So it does make it difficult to go back to school due to financial reasons and
Thank,
working full time.
yeah, thank you for bringing that up.
I do not see myself as a nurse. Maybe at some point, yes, it did, came through my mind, but right now, I'm I'm more like the administrative path, so that's what I'm going for.
Well, yeah, and there are pipelines in any number of ways, administrative pathways, clinical pathways, and in many ways, Stephanie, you're already doing that as an MA supervisor. So
Okay.
it's just, again, we have two stories and two different examples of what being an MA and taking on an expanded role in practice looks like. I want to ask, there's a really interesting comment in the chat around MA instructors of color and including health and wellness components of trainings in those trainings. And so I'd love for that person to clarify in terms of health and wellness in patient education. So health and wellness to support chronic disease management, or health and wellness in terms of taking care of MAs themselves and preventing self-care and preventing burnout. So if you have any more thoughts there, please drop that into the chat and I can be sure to incorporate that into the discussion. I'll also say, last call, everyone. We have just a few minutes left, and I'm so grateful for all the wonderful comments and questions that you've posed. So if you have any last burning questions, please do feel free to put them in there. I'll lift up the one that I saw come through already, which is we've spent so much time focusing on team-based care and how you all work together in your pods and in patient prep and otherwise, and how that works well for you all. Beyond staffing, are there things that pose barriers to the team working well together? I mean, Phylisha, as one example, you talked about having to manually call down the hall to bring a nurse over to do vaccinations, and now you've used Teams. But what other pain points, to crib a term from the chat, what other pain points do you see in terms of the team working well together to serve patients in your community health centers?
I guess it's having a good communication between everybody, that everybody understands each one's roles in patient care. Um, for example, I am not going to go above a provider, right? I know that's a provider job. So he knows medical speaking, he knows more than me, but also the provider has to understand that MAs have a role and they are expected to do some things. If you're not okay with that, that's okay, but just let the MAs do, what they're supposed to do. And it's just having a good communication between everybody. Because when you don't have that communication, then the day does not go as well as it should be.
Stephanie, I think that's so important around, we've talked about policies and big picture things like staffing and
Mhm.
wages that can make the work better, and such an important part of that is the interpersonal and the communications and the ways teams work better, not just with a workflow, but also just the
Right.
communication between team members. And I think it's so important that you bring that up. Felicia, any thoughts for you?
And no, I definitely agree. Communication is key in any role in the medical field, from the the girls that check patients in to check patients out, anyone that's answering the phones. Communication is truly key, and efficient communication. You know, how quickly things are being told to one another.
Thank you. And thank you for affirming that.
Mhm.
I this hour's flown by. It's a sign of a good conversation that we've had a lot to discuss and we've had folks ask a lot of questions. So I want to first of all just lift up what we've seen a lot in the chat just now, which is a lot of thanks. So thank you so much for this conversation. Thank you for the work that you do. I'm so glad to see that folks got a lot out of the conversation. I'll lift up a few last things I've seen in the chat. One, thank you to the comments around MA training and the importance of training MAs on health and wellness for patients in terms of chronic disease management, mental health, self-care. And thanks to those who brought up all of your different ideas around training and the policy requirements around training. Thanks to those of you who expressed your own experiences in clinic and as educational specialists and otherwise. So, and thank you for all the policy information around this current policy proposal in terms of MAs being able to vaccinate. The last thing I wanted to do in terms of offering a resource is we very briefly mentioned different types of training pathways. And one training pathway we alluded to is an apprenticeship model for MAs to be trained in practice and for experienced MAs to be able to support those MAs in training. And I just directed folks to a description of an apprenticeship program, the first of its kind here in New York State, that we at the New York Health Foundation are really pleased to be able to support in federally qualified health centers across the state, including Open Door. So I would use that to say, check that out. Stay connected with us at the New York Health Foundation. We want to keep hearing from you. We want to continue to have conversations around medical assistants work in primary care and the communication and the practice changes and the policies needed to support them. So with that, I will just close this out by saying, once again, thank you, Stephanie, Phylisha. Thank you so much for your time.
Thank you
Thank
so
you all
much.
for joining us and for being so invested in the chat. And we will follow up with a recording and ways for you to stay connected with all of us. But appreciate all your time this afternoon.